So, our pathway today covers 5 key areas. First, the influencing factors of healing. Second, the intentions of closure. Third, objective classification systems. Fourth, traumatic soft tissue injuries. And finally, acute surgical emergencies. Let's get to it.
Starting off with Section 1, Influencing Factors. You see, before a surgeon can even begin to manage a wound effectively, we absolutely have to understand the baseline factors that dictate how human tissue heals in the first place. First up, we have local factors. These are basically localized roadblocks right at the site of the injury that can stall or even totally prevent healing. Just imagine a wound trying to knit itself together. If there's high skin tension actively pulling it apart, or hypoxia and vascular insufficiency completely depriving it of oxygen and blood flow, well, it simply isn't going to heal. Add in local complications like lymphedema, visible contamination, an active infection, maybe some retained foreign bodies, or previous radiotherapy to that specific area, and suddenly that local environment becomes incredibly hostile to cellular repair.
Now, zooming out to the whole patient, systemic factors act as global roadblocks to recovery. Basically, an individual's overall health profile fundamentally alters their capacity to heal. Things like advancing age, obesity, malnutrition, and smoking all drastically impair tissue repair across the board. Furthermore, systemic diseases like diabetes or connective tissue diseases, immunocompromised states like AIDS, and certain medications, specifically steroids, immunosuppressants, and chemotherapy, well, they can completely undermine the body's natural healing pathways from the inside out.
Moving right along to Section 2, the intentions of closure. Understanding those roadblocks we just went over is absolutely critical because those exact factors dictate the very next logical step, which is how surgeons deliberately choose to close these wounds. And this brilliantly illustrates the 3 distinct surgical strategies or intentions for wound closure. Primary or first intention is your ideal scenario, direct surgical apposition that leaves a minimal scar. But if the wound is highly contaminated or messy, we pivot to delayed primary, also known as tertiary intention. Here, the wound is deliberately left open at first, debrided, and then surgically closed later, but only once we're sure it's clean. Finally, secondary intention is when the wound is left completely open to heal entirely on its own, through native granulation, contraction, and reepithelialization. While sometimes absolutely necessary, this approach definitely results in a significantly poorer scar. Which brings us to Section 3, Objective Classification Systems. To make these crucial closure decisions, surgeons aren't just guessing out there. They rely on strict objective scoring systems to measure clinical risk. So, let's walk through the CDC Surgical Wound Classification System, which measures contamination risk as it escalates row by row. Class 1 is a clean wound. It's uninfected, there's no inflammation, and the respiratory, alimentary, genital, or urinary tracts are completely bypassed. These are usually closed primarily. Class 2 is clean contaminated. Here, those tracts actually are entered, but under tightly controlled conditions without any unusual contamination or major breaks in sterile technique. Things get a lot more serious in Class 3, which is contaminated. Think open, fresh, accidental wounds or surgeries with gross GI spillage, acute non-purulent inflammation, or major sterile breaks. Finally, Class 4 is dirty. This means old traumatic wounds with retained devitalized tissue, an existing infection, or a perforated viscera. So the crucial point is how this classification actually ties in to predicting real-world infection risk. The NNIS score predicts surgical site infection risk mathematically on a super simple 0 to 3 scale. You get exactly 1 point for each of the following: having a Class 3 or Class 4 wound, having an ASA score of 3 or higher, and finally, if the operative time exceeds the 75th percentile of the expected duration for that specific procedure. Add those up, and the surgeon instantly has an objective risk profile.
Okay, we are really escalating the stakes now. Welcome to Section 4, Traumatic Soft Tissue Injuries. We're talking about injuries that throw immediate mechanical and biological challenges right at the surgical teams.
Let's start with bites. Now, they frequently present as punctures or avulsions, but we absolutely have to pay special attention to the clenched fist injury. Any wound over the MCP joint, so basically the knuckle, must be treated as a human bite from a punch, and this is so vital to understand. MCP joint involvement is a straight-up surgical emergency. Why? Because the bacterial inoculation from a human mouth will rapidly and aggressively destroy the articular cartilage right inside that joint. Another major traumatic challenge is degloving. This happens when severe shearing forces literally rip the skin and subcutaneous fat right off the underlying deep fascia and muscle. But there's actually a stealthy, closed version of this called the Morel-Lavalley lesion. In this pathology, severe internal shearing forces create a potential space underneath the skin, and that space fills up with a characteristic hemolymphatic collection. Classically, this hidden, fluid-filled lesion sets up shop right over the greater trochanter of the hip. Managing these degloving injuries relies on a super strict three-step protocol, mainly because tissue viability is notoriously tough to judge. Step 1. Surgeons have to serially excise the compromised tissue until punctate dermal bleeding appears. Basically, that bleeding is your proof that the tissue still has a blood supply. Step 2. To help figure out the exact boundaries of living versus dead tissue, surgeons use special dyes, specifically fluorescein or indocyanine green. And tragically, step 3, if the patient comes in with severe multiplanar degloving, the surgical team might actually have to consider primary amputation. All right, we have reached the final and most critical phase of our explainer. Section 5, acute surgical emergencies. When we talk about these life-threatening soft tissue conditions, time is quite literally tissue. First on the list is acute compartment syndrome. This triggers when there's increased pressure inside a closed osteofascial compartment. That pressure causes immediate microvascular compromise, essentially choking off the blood supply to the muscle. But the absolute hallmark clinical sign here, the massive red flag you must remember, is pain out of proportion to the injury. And you'll see this especially during passive movement of those affected muscles. Because those clinical signs can sometimes feel a bit subjective, surgeons rely on a very specific numerical threshold using needle monitoring. The definitive diagnostic trigger is an intracompartmental pressure, or ICP, that comes within 30 millimeters of mercury or less of the patient's diastolic blood pressure. When that pressure closes in on the diastolic pressure by 30 points or less, you have a confirmed, undeniable emergency. And the required action is absolute. The emergency intervention here is an urgent fasciotomy. For example, doing a 2-incision, 4-compartment decompression in the lower leg to slice open the fascia and instantly release that suffocating pressure. If this treatment is delayed, though, the consequences are genuinely catastrophic. The dying muscle releases toxins causing rhabdomyolysis, which can lead to amputation or ultimately even death. Our final emergency is necrotizing fasciitis. This is a rapidly spreading, entirely life-threatening soft tissue and fascial infection. The stakes are immense. We're talking about a 30-day mortality rate of up to 26%. Now, while it can definitely be polymicrobial, a highly frequent monomicrobial culprit is Streptococcus pyogenes, which you probably know as Group A strep. Furthermore, thinking back on those systemic risk factors we covered earlier, diabetes is far and away the most common comorbidity associated with this devastating infection. Now, what's really interesting about this next point is the diagnosis. It relies on very distinct visceral clinical signs: severe pain, crepitus, which is this terrifying crackling feeling right under the skin caused by gas-producing bacteria, and a highly specific, characteristic grayish drainage famously known in the surgical world as dishwater pus. That specific visual and textural presentation is an absolute massive red flag. Once diagnosed, a strict, life-saving 3-step protocol kicks in. First up, immediately administer broad-spectrum IV antibiotics to start fighting the infection systemically. Second, get that patient to the OR right away for emergency radical surgical debridement. They have to physically cut away all infected and dead tissue to halt the spread. And third, the protocol demands a mandatory scheduled 24 to 48-hour second look operation just to ensure that the infection hasn't sneakily continued to advance. Which really brings us to our final thought. We've traced the entire path today from basic wound healing factors all the way to catastrophic emergencies. So, given the rapid devastation of necrotizing infections, how quickly could a simple Class 1 surgical wound theoretically devolve into an absolute nightmare if local and systemic risk factors are entirely ignored by the clinical team? It really underscores why understanding these foundational principles isn't just academic theory, it's quite literally what saves lives. Well, that wraps up our deep dive into the source material for today. Thanks so much for joining me on this explainer, and I'll catch you in the next one.